Welcome back to the Deep Dive. If you need a shortcut to being genuinely well-informed on a topic that might seem, well, incredibly technical,
Yeah.
you have definitely come to the right place.
Mm-hmm.
Today, we're taking you right into the operating room. We're focusing on some of the most critical and, honestly, powerful tools used in modern medicine.
We're talking about the energy devices that allow surgeons to cut, to coagulate, and to seal tissue during minimal access procedures.
And these tools are, they're just miracles of physics and engineering,
Yeah.
but they operate at such high energy that they demand absolute mastery.
Oh, absolutely. In the confined space of a laparoscopic procedure, the difference between a perfect seal and a catastrophic complication, it often comes down to the precise control of heat and current.
So our mission today is to really unpack the intricate technology, the foundational physics, and the rigorous safety rules that govern these essential instruments.
Yeah.
For this deep dive, we're really leaning on the incredible and detailed technical knowledge compiled by Dr. Senthil Kumaran K., who is an associate professor of surgery at AIIMS Nagpur. His material provides just a crucial roadmap to safe surgical practice.
And that expertise is vital because at the end of the day, we're dealing with controlled destruction.
That's a great way to put it.
And while the tools we use today are, completely cutting edge, the foundational principle is ancient.
Yeah.
We're essentially returning to the wisdom that I think it was Thomas Edison who championed it. When all else fails, turn to heat.
Right.
Controlled heat has been used therapeutically for millennia, and modern electrosurgery is simply the most refined, most controlled application of that thermal energy, just delivered via an electrical current.
So we're talking about high-stakes physics applied inside the human body.
Mm-hmm.
In minimal access surgery, the selection of the optimum energy device for a specific technique, whether you're delicately dissecting tissue or trying to seal off a major artery, that's a moment-to-moment decision.
It really is.
But to fully appreciate the complex intelligent systems available now, we have to start with the foundational technology, the one that also happens to harbor the greatest inherent risk.
Monopolar energy.
Monopolar energy.
Yeah.
Okay, so let's unpack this standard monopolar circuit, because getting this right, it seems like the absolute first line of defense against patient injury. Walk us through it.
It is. It's a full loop, right? It has to be a complete circuit.
Starting with the generator.
Right, the generator. That's what's creating the current. It goes down the cable to what we call the active electrode.
And that's the actual tool the surgeon is using, the hook or...
Exactly. The hook, the spatula, scissors, you name it. That's what touches the patient's tissue.
Okay, so the current goes through the tissue, does its job.
And then it has to get out. And this part is crucial. It exits through the patient return electrode.
The big sticky pad.
The big sticky pad, yeah. That's the access pad. And from there, it's back to the generator. Loop complete.
It sounds so simple on paper. Power goes in, does its work, comes out. But if the current seeks the path of least resistance, where does this danger of a remote injury come from?
The danger is baked right into the system because the patient is effectively part of the external circuit.
Okay.
So if that primary pathway, that wide, safe return electrode is compromised in any way, or if an alternative, easier pathway back to the ground emerges, the current will take it.
It'll take the shortcut.
Always. And that shortcut often results in a remote injury, a burn that occurs far, far away from where the surgeon is actively working.
Can you give us a tangible example? Like, how could that happen in a real OR setup?
Oh, easily. Think about how the patient is positioned. If their thigh, for example, just inadvertently brushes against a metal part of the operating table, or maybe their arm rests against a metal arm stand that's somehow grounded. If the current finds that path, that tiny point of contact suddenly becomes the exit site.
And because it's so small...
Exactly. Because that contact area is tiny, the current density right there is incredibly high. And that leads to a severe, deep, localized burn that the surgical team, they might not even notice it until hours later.
Wow. So the very first, most fundamental safety protocol isn't even about the machine. It's about preparation. It's metal removal.
Absolutely essential. Any piece of metal on the patient, I don't care how small, can become a conduit, an unintended return electrode.
Rings, necklaces.
All of it. Rings, necklaces, bracelets, all must be removed. And if an ornament is, irremovable like a wedding band on a swollen finger, it has to be aggressively insulated.
How do you do that?
with thick bandages, sponges, whatever it takes to ensure that metal cannot come into contact with any external metal fixture. You just have to eliminate the risk of that alternative pathway entirely.
Okay, so beyond that physical preparation, the generator itself has to stick to some pretty strict technical specifications. This isn't just plugging in a power tool. What's the fundamental requirement for the current's frequency?
The frequency is probably the most critical parameter for preventing neurological side effects.
Yep.
Your standard household current is low frequency. And if surgical current operates at less than 100 kilohertz or kilohertz, it causes nerve and muscle stimulation.
So the patient would actually feel it, they'd twitch.
They'd experience painful spasms, twitching, even a full electric shock sensation. It's incredibly dangerous. So to bypass the neuromuscular system entirely, we have to use a current above 100 kilohertz.
And what's the ideal range?
For optimal, safe electrosurgery, the frequency range is much, much higher, typically between 500 kilohertz and 3.3 megahertz.
That makes perfect sense. The current moves so fast the nerves just can't respond to it.
That's the idea.
Now let's get into the real physics of tissue damage. You mentioned something called the Byrne equation. How does this formula current intensity, time, and area dictate safety?
This is the law. It's the law governing surgical heat application. If we violate any part of this equation, we guarantee a burn injury.
All right, let's start with the easiest one to regulate. Current intensity or the wattage. What's the safe ceiling for that?
Well, if you're using a standard, well-maintained generator, something like the widely used Force FX machine, the current intensity for routine laparoscopic work should never, ever exceed 40 watts.
40 watts is the maximum.
That 40-watt ceiling is the optimum maximum. Pushing beyond that just dramatically increases the thermal damage potential. Surgeons should always start low and only increase it if it's absolutely necessary for, say, really dense tissue.
Okay, next up is time. This is the duration of the energy application, which is controlled by the surgeon's foot pedal. And this is where the crucial intermittent rule comes in.
Yes, and this rule must be followed religiously. The activation time should never exceed 3 seconds continuously.
Why 3 seconds?
Because heat is cumulative. Prolonged, continuous application causes massive thermal spread and severe collateral damage to healthy tissue. So if a surgeon thinks a process needs, say, 9 seconds of energy,
They can't just hold the pedal down for 9 seconds.
absolutely not. It has to be delivered as 3 distinct 3-second impulses. You give it a brief pause in between to let the tissue cool just a little bit and let moisture come back into the area.
Okay, and finally, area. This is where the concept of remote injury gets really complex. It's not just about external metal contact anymore, but internal tissue injury. We're talking about the critical 6-millimeter rule.
Yes. This is perhaps the most profound technical insight when it comes to monopolar. You never, ever hold more than 6 millimeters of tissue at one time with a monopolar device.
And the principle here is current density.
Exactly. The electron current is looking for the narrowest available path to get out of the tissue and complete the circuit at the electrode tip.
So what happens if the surgeon grabs, 10 millimeters of tissue, exceeding that limit? What's the chain reaction that causes that remote internal burn?
Well, it's counterintuitive. If you hold 10 millimeter, the current disperses really widely across that tissue. So the burn is actually less severe right where the surgeon is clamped.
So it seems like it's not working properly.
Right, it seems ineffective, but here's the problem. When that dispersed current has to converge back into a narrow point to exit the body, it concentrates somewhere else.
And that's the remote injury.
That is the remote injury. The current might travel along some unseen tissue plane and burn the bowel or injure the common bile duct, a vital structure, even though the monopolar hook was being used nowhere near those areas. Maybe it was down by the uterus. It's an internal failure to control the geometry of the current density.
That is genuinely fascinating and terrifying. The burn happens because the current is improperly dispersed where it's supposed to work, forcing it to concentrate somewhere else entirely.
It just highlights why monopolar use demands such extreme discipline. That 6 millimeter rule is everything.
Okay, last piece of this puzzle. The patient return plate itself. The pad that's supposed to safely dissipate all that current. What are the non-negotiable rules for placing it?
If this pad is placed improperly, the pad itself becomes the site of a severe burn. The rules are absolute.
Number 1.
It must be applied to a well-vascularized muscle mass. Muscle tissue has a great blood supply, so it acts like a heat sink. It safely dissipates the thermal energy.
So you have to avoid, what, bone?
Absolutely. Avoid bony prominences, hips, elbows, knees. Also, irregular body contours or any areas with known vascular insufficiency, because that would prevent effective cooling. If you put it over bone, the heat has nowhere to go but inward, causing these awful deep burns.
And placement close to the surgery site.
As near the incision site as possible, it shortens the circuit path. And maybe most importantly, the minimum contact area must be 100 square centimeters.
That's a big area.
It has to be. You need that wide area to ensure the current intensity is diluted enough to prevent localized heating.
And I imagine those deep burns from a bad pad placement take months to heal.
Months. And that makes this a huge medical legal issue. It really emphasizes that this is about team protocol, not just the surgeon's skill.
Okay, so this exhaustive review of all the monopolar risks, remote injury, the 6 mm limit, all these pad rules, it really shows why the development of bipolar technology was such a necessary evolution. What's a fundamental difference that makes bipolar inherently safer?
Well, bipolar eliminates that danger of remote injury entirely. It closes the circuit locally.
How does it do that?
In a bipolar device, the instrument's jaws contain both electrodes, the active one, the positive pole, and the return electrode, the negative pole.
So the current is contained entirely within the tissue that's being gripped by the instrument. It doesn't need the patient's body or an external pad to complete the circuit.
Exactly. The current path is strictly localized. It only travels across the tissue clamped between those two jaws.
Good to know.
It means bipolar devices cannot cause a remote injury. Full stop. You could be holding a huge bundle of tissue, say 15 millimeters, and while you might risk some local collateral damage, you will not cause an unseen burn somewhere else in the body. That whole danger of alternative pathways is just gone.
And you can usually spot these instruments, right? Bipolar dissectors, graspers, they have that plastic insulation separating the two metal poles.
Correct. That insulation is the key. It ensures the current flows laterally between the poles, and functionally, the distinction is also crystal clear. Monopolar should primarily be for fine, clean cutting.
And bipolar is for.
Bipolar is the preferred tool for robust coagulation, for sealing larger vessels and tissue planes, precisely because coagulation often requires grasping a larger amount of tissue than that monopolar 6 mm rule would ever permit.
Right. That said, even though bipolar prevents remote injury, it doesn't eliminate all thermal damage risk. We still have to worry about local collateral damage.
That's a critical point. You're right. Bipolar is safer, but that local thermal spread, the heat leaching into the healthy adjacent tissue, is still a very real concern.
And the technique to minimize it is the same as the monopolar rule.
It's the same time rule. We have to use multiple small interrupted applications. The goal is to get the tissue to that 80° C fusion point and then stop, preventing the heat from soaking deeper into the surrounding area. Brief pulses, less than 3 seconds each, are paramount.
That distinction you made, cutting versus coagulation, is really what defines the technology. We should probably go deeper into the physics of what's happening to the tissue, which raises an important question. What exactly is coagulation, and how does the generator produce that sealing effect as opposed to a rapid, clean cut?
To really understand that functional difference, we have to look at the 3 main waveforms the generator produces: pure cut, coagulation, and blend. They're defined by their frequency, their voltage, and most importantly, the duty cycle, how often the generator is actually running.
Okay, let's start with pure cut mode. What is happening on a cellular level?
So pure cut uses a high-frequency, low-voltage current. The generator is 100% N, it's just continuous energy. This maximal frequency causes what we call ion turbulence. The energy is so intense and rapid that it fractures the cell membrane, causing the cytoplasm, which is mostly water, to instantly boil and burst out.
It's a rapid evaporation.
It's basically flash boiling the cells. The tissue just gives way cleanly. Now, this mode requires the surgeon to apply traction to pull the tissue taut to ensure a clean separation. It's used for really delicate, precise dissection.
Like what?
Like cutting the peritoneum or opening the common bile duct.
Okay, now compare that continuous power to coagulation mode.
Coagulation is the complete opposite. It uses a low-frequency, high-voltage current, but here's the key. The generator is only 6% ON.
Only 6%.
Yeah, for 94% of the time, the energy is off. This creates these short, intense energy spikes separated by pauses. And because the energy is intermittent, the cell membrane doesn't burst. Instead, the heat builds up slowly inside the cell. And this slow, controlled heating causes the tissue components to change state.
And this heat brings us back to those critical thermal markers. What are the key temperatures that surgeons need to be thinking about?
There are 3 critical thermal thresholds. The process starts at around 55 degrees Celsius. That's where protein coagulation begins. The tissue starts to firm up.
And the goal is?
The goal temperature, the sealing temperature, is 80 degrees Celsius. At 80 degrees, the structural components of the tissue, the collagen and the elastin, they actually melt and fuse together. That creates a permanent, stable seal. That's the whole objective of coagulation.
And what happens if the surgeon pushes past that ideal 80-degree mark?
This is the absolute safety limit, 100 degrees Celsius. If the temperature exceeds 100 degrees, the melted elastin and collagen, they burn. They dehydrate completely, turning into this black, non-conductive charcoal.
And that's bad.
It's terrible. The char is brittle, it sloughs off, and bleeding starts all over again. In the operating field, the surgeon must only look for vapor, steam rising from the tissue, which just means water is bubbling, not smoke.
Smoke means charring.
Smoke means charring, and charring means the procedure has failed locally. It means the surgeon has to stop, clean the instrument, and start again.
That visualization vapor, good, smoke bad, is such a clear and simple indicator. So the third mode is blend, which I assume combines aspects of both.
Exactly. Blend mode, it's often the yellow paddle on the machine, is an intermediate setting. Blend 1 is closer to a cut. Blend 3 is closer to coagulation.
And when would you use that?
You use it for dense vascular or muscular tissues. Think about a myomectomy, removing uterine fibroids, or a liver resection, or a partial nephrectomy. It lets the surgeon move forward, cutting the tissue while immediately sealing the small vessels they encounter at the same time. It's a compromise between speed and hemostasis.
We also need to drill down on the two distinct ways coagulation is performed: desiccation and fulguration. These differ entirely based on whether the electrode makes contact, right?
Right. Desiccation means coagulation with form contact. The electrode is in direct physical contact with the tissue.
And this is for sealing big vessels.
Mandatory for it, like the uterine artery. That direct contact allows the concentrated heat to shrink the vessel lumen and fuse the collagen and elastin. And remember, standard bipolar devices can only perform desiccation.
Okay, so that's desiccation. Then fulguration, or spray mode, is non-contact.
Correct. Fulguration means holding the active electrode slightly away from the tissue, maybe 0.5 millimeter to 1 millimeter away. This creates an arc, a spray of current. And the crucial difference here is that with fulguration, the width of the injury is greater, but the depth of the injury is less.
Why is that depth limitation so advantageous in certain scenarios?
It's absolutely vital for delicate or sensitive anatomy. For instance, if you're treating superficial bleeding on the liver bed during a gallbladder surgery, or you're addressing endometriotic spots that are lying directly over the rectum or the bladder.
Ah, I see.
You need to coagulate the surface, but you absolutely cannot risk deep thermal penetration that might perforate the organ underneath. Fulguration achieves that broad, shallow surface coagulation safely.
So, just to recap for you listening, if I'm sealing a vessel, I need desiccation and direct contact. If I'm trying to lightly cauterize a large, flat surface near critical structures, I need fulguration.
That is the essential rule. Knowing the right mode for the tissue and the surrounding context, that's what separates the masters of energy use.
Okay, let's try to synthesize this by bringing all the operational variables together that dictate success, hemostasis, or failure, which is bleeding.
Yeah, we can boil it down to 6 main variables that have to be controlled.
Go ahead.
First, waveform, choosing the correct mode cut, desiccation, or fulguration. Second, power setting, sticking to that 40-watt max rule. Third, time, strictly observing a 3-second maximum for continuous activation.
And fourth.
Fourth is electrode manipulation. Technique matters hugely. Cutting requires traction, pulling the tissue taut. Coagulation and sealing require relaxation, holding the tissue without tension to allow the proteins to shrink and fuse properly. If you pull on it while you're coagulating, you just tear the seal apart.
Makes sense. What are the last two?
Fifth is tissue type. You have to adjust the power based on water content. Soft, wet tissue like a fallopian tube needs less power. Dense, dry tissue like a fibroid or a ligament needs more power to hit that 80-degree C mark.
Number 6.
Char formation. We talked about char. It's an insulator. If the electrode is covered in black gunk, it blocks the current flow. The instrument effectively stops working. The surgeon has to routinely stop and clean the electrode to maintain effectiveness. It's a crucial but often overlooked technical detail.
We've laid all the groundwork with the fundamentals. Now we can move into the truly intelligent and specialized devices designed to manage these variables automatically and enhance safety and efficiency. This is where the tech goes way beyond simple electrical current.
Our first stop in this advanced toolkit is argon-enhanced electrosurgery, or as it's often called, the argon beamer. This is essentially a massive enhancement of that fulguration concept we just discussed.
So how does argon gas act as a better conductor for the current than just plain air?
Well, argon is an inert gas, and it's an excellent electrical conductor, much like its cousin xenon. In this system, argon gas is continuously streamed out, creating this plume that transfers the current from the electrode to the target tissue.
And what's the benefit of that conducting gas plume?
It dramatically increases the distance over which we can fulgurate.
Really?
Oh, yeah. Standard minipolar fulguration works from, half a millimeter to 1 millimeter away? The argon beamer allows for effective coagulation from 1 to 2 centimeters away.
1 to 2 centimeters. That's a huge increase in working distance. Why is it so important?
It is the ultimate tool for broad superficial hemostasis with maximum safety. Because the current is delivered via this wide diffusing gas beam, the width of the injury is large, but the depth is incredibly shallow.
So it's perfect for large areas of oozing.
Exactly, like managing the surface after a liver resection, or widespread bleeding after a partial nephrectomy, or those diffuse endometriotic implants on the bowel surface. The distance guarantees that deeper, critical organs are protected from penetration.
Okay, next up, we have tripolar devices, which sounds like an elegant solution to the problem of constantly changing instruments.
That's exactly what they are. They simplify the operative steps. They're basically bipolar instruments designed for sealing, but they have an integrated, retractable cutting blade built right into the head of the instrument.
That must save a significant amount of time in long or complex cases.
It's a massive efficiency boost. Imagine doing a splenectomy where you have to constantly seal and divide multiple short gastric vessels. Instead of seal with bipolar, take out the bipolar, put in the scissors, take out the scissors, put the bipolar back in.
Over and over again.
Right. Instead, the surgeon can seal the vessel with the bipolar jaws, deploy the integrated blade with a lever, cut the sealed tissue, and retract the blade, all in a matter of seconds with just one instrument.
Now let's talk about the real game changer. The one that completely bypasses all the electrical safety risks, the harmonic scalpel. This uses mechanical energy. How does a piece of metal vibrating 55,000 times a second cut and seal tissue?
It's incredible, really. It uses a transducer that contains a piezoelectric crystal. When you apply electricity to this crystal, it changes shape rapidly, and that generates these incredibly fast linear vibrations. This vibration generates pure friction energy, not electrical current.
So it's the friction that's doing the work.
It cuts tissue by cavitation, and it seals by denaturing protein via controlled, localized heat created purely by friction.
So because it's not using electrical current, all those risks we spent the first part of our conversation on, remote injury, capacitated coupling, pacemaker interference, they're all completely eliminated.
Absolutely. That is its primary safety advantage. And what's more, the heat profile is vastly superior.
How so?
Electrical coagulation can reach 200, even 300 degrees C, risking char. The harmonic scalpel's fiction heat maxes out between 80 degrees C and 100 degrees C.
So it stays in that perfect sealing zone.
Exactly. That lower heat means significantly less collateral damage, less tissue necrosis, and far less char formation. You get a much more stable seal. It is the absolute gold standard for patients with pacemakers.
I understand the harmonic has a critical safety feature related to its two jaws, the active jaw and the Teflon jaw.
Yes, the technique is very precise. One jaw vibrates and does the work. The opposite jaw is the Teflon jaw, that's the inactive jaw. And the Teflon jaw should always be strategically placed toward the sensitive or critical anatomy.
Like a major vessel or the bowel.
Right, a vessel, the ureter, the bowel. Since the Teflon jaw is inert, it won't transfer friction energy or heat, and it offers this layer of protection to the sensitive structure even if contact is made. The vibrating jaw has to always be under direct, clear vision.
And tell us more about the intelligence built into modern versions, the adaptive tissue technology.
This is its modern refinement. The scalpel is sensing the tissue's strength and composition in real time. So if the instrument encounters hard, dense tissue, like a thick ligament, the technology automatically increases the vibration power to ensure there's enough friction energy.
And if it's soft tissue?
If it hits soft, water-rich tissue, it decreases the power. This makes the sealing consistent no matter what the surgeon is grasping.
Moving back to electrosurgery, we have the truly intelligent bipolars, ligature and end seal, which have processors that monitor the tissue's state. Let's look at ligature first. How does this tissue response electrosurgical generator work on impedance technology?
Okay, so impedance is just the tissue's resistance to electrical current. As tissue heats up, the water evaporates and the tissue dries out. This dehydration dramatically increases the tissue's impedance.
And ligature is programmed to recognize that spike in impedance.
It's looking for the curve of that spike,
Yeah.
precisely. It can sense when the collagen has fused and the tissue has dried to a point of maximum structural integrity. When the impedance hits that predetermined critical point, which indicates a successful seal, the generator automatically stops the energy output.
Wow. So it prevents overcooking before the surgeon even has a chance to lift their foot off the pedal.
It does, and that automation, that intelligent control, is why ligature can safely seal vessels up to 7 millimeters in diameter. We're talking about things like the splenic artery, with minimal collateral damage, usually only about 2 millimeters of thermal spread.
And I assume it also has an integrated cutting blade.
The newest versions usually do, yeah, for efficiency.
So what makes ENSEAL the comparable tissue response generator distinct?
ENSEAL operates on the same impedance sensing principle, but it offers a major mechanical advantage: articulation.
It bends.
It includes a rotating knob that allows the jaws to bend or angle up to 60 degrees. This gives the surgeon a far superior manipulation angle, which is exceptionally useful when you're operating deep in the pelvis or when you're using an instrument from a port on the same side of the body as your target.
And finally, the ultimate combination device, the Thunderbeat.
Ah, the Thunderbeat. Developed by Olympus, it combines the best of both worlds into a single instrument.
How does it do that?
It marries ultrasonic energy, that friction-based method that's best for clean cutting with bipolar energy, the intelligent impedance sensing tech that's best for sealing those big 7 millimeter vessels. One instrument does both cutting and advanced sealing efficiently. It just maximizes versatility and safety.
We've established that minimal access surgery, while less invasive, introduces these unique hazards related to the physics of high-energy tools operating, partially blind within the abdomen.
Mm-hmm.
We need to detail the 5 major pitfalls that frequently lead to catastrophic and often delayed complications.
Yeah, and these mistakes are less about poor anatomical knowledge and more about a failure to respect the physics and the limitations of the instruments.
Okay, so let's detail the first one, overshooting.
Overshooting is a failure of visualization and control. It happens when the tip of the instrument goes just slightly beyond the surgeon's intended field of application. Imagine working deep in the pelvis, near what they call the triangle of doom. The surgeon is focused on a tiny vessel, but the energized tip momentarily strays over the iliac vessels. The result is often a severe, immediate, uncontrolled injury to a major artery or vein. It requires an immediate, frantic conversion to open surgery just to save the patient's life.
The second pitfall relates directly to that 100-degree C limit we discussed earlier. It's called overcooking.
Overcooking is just applying energy for too long, breaking that 3-second rule. It turns the tissue black, and that's unstable charcoal. Later in the procedure, when the surgeon or an assistant manipulates that area, that charred tissue inevitably sloughs off, and that causes a sudden reactionary bleed.
And that bleeding then leads to a cascade of further risk.
Precisely. The surgeon is now under pressure, trying to secure the bleeder quickly. In their haste, they often inadvertently burn or grasp an adjacent vital structure, like the ureter, which is incredibly difficult to repair laparoscopically. Overcooking starts that whole domino effect of complications.
Mistake number 3 is maybe the most deceptive, because the injury is often unseen during the initial operation. Direct coupling.
Direct coupling is a dangerous transfer of energy. It happens when the active electrode touches any other uninsulated metal instrument, a metal suction tip, a needle holder, even the camera scope, which is simultaneously touching tissue somewhere else.
So the current just jumps from one instrument to the other.
Instantly. It couples to that second instrument. And if that second instrument is touching the bowel, out of the field of view, the surgeon doesn't see the burn happen.
That's the silent killer.
It is. That current causes a small, localized burn to the bowel that might look trivial at the time. But over the next 48 to 72 hours, that area progresses to necrosis. We see this classic pattern in delayed complications. Bleeding on day 1, maybe a bile or bladder injury on day 2, and unfortunately, bowel perforation on day 3. And that third-day perforation is so often traced back to an unseen direct coupling injury.
Wow. Okay, moving to mistake number 4. A maintenance failure that is completely preventable, insulation failure.
This is so common with reusable instruments. The plastic coating on the shaft gets damaged. It gets nicked by cleaning staff, worn down by other instruments rubbing against it. And the danger is that the surgeon is focused intently on the tip of the instrument.
but the current is leaking out of the shaft somewhere else.
Yes. The current leaks from that fault in the shaft, causing an unseen burn to tissue that's just resting against it, far away from the active tip.
So the surgeon assumes they're operating safely, but the current is essentially arsing from that defective point.
Exactly. The integrity of that insulation has to be checked meticulously before every single procedure.
And finally, the unique physics problem that requires a very specific setup: capacitative coupling.
Capacitative coupling is an electrostatic charge issue, and it happens exclusively when surgeons use a hybrid cannula system.
What's that?
It means a conductive metal instrument shaft is placed inside a non-conductive plastic outer cannula or port. As current passes through the metal shaft, an electrostatic charge builds up on the metal. But because the plastic sleeve is an insulator, the charge can't safely dissipate into the patient's abdominal wall.
So the charge just builds and builds until it has nowhere else to go.
Right. It accumulates until it reaches a critical voltage and eventually fires onto the nearest conductive tissue, which is often the adjacent bowel. This electrostatic discharge causes a significant, often delayed, thermal injury. It's a secondary current, completely separate from the primary one.
And this risk is why it's so strongly recommended to avoid hybrid systems entirely.
Yes. The safest choice is always an all-metal cannula system. If any charge builds up, the metal sleeve grounds it harmlessly to the abdominal wall. It completely eliminates the risk of that internal electrostatic discharge.
Fortunately, technology has come up with a protective measure against these insidious coupling and insulation risks: AEM technology, the Active Electrode Monitoring System.
AEM technology is an incredibly valuable safety net. It's basically a miniature circuit breaker built into the generator system.
And it's always watching the circuit.
Continuously. It monitors the electrical flow. If it detects conditions that indicate direct coupling or capacitative coupling, or an insulation failure, like a sudden, dangerous change in impedance, it immediately and autonomously breaks the circuit. It stops the energy from reaching the tissue, neutralizing the risk before the burn can even happen.
So it's a technology that really should be a priority in any modern surgical setting.
It should be standard.
We've navigated a huge amount of information, from the necessary violence of a 6% duty cycle to the controlled chaos of the harmonic scalpel. It all boils down to a concise set of actionable safety recommendations. What are the key takeaways for safe energy use?
We can really consolidate these into 7 critical rules for optimal outcomes.
Let's hear them.
1. Vigilance. Always, without fail, inspect the insulation on reusable instruments. A minute spent inspecting saves months of recovery.
2. Power.
Use the lowest possible power setting required for the job. We're aiming for coagulation, not charring. 40 watts should be the routine maximum.
3. Mode choice.
Prioritize cut mode over coagulation where technically appropriate. Pure cutting causes less tissue necrosis.
4. Time.
Adhere to that brief intermittent activation rule, maximum of 3 seconds continuous.
5. The activation mantra.
Never activate in an open circuit. Before every single activation, the surgeon must follow the mantra. Hook, look, and cook. Hook the tissue, visually look to confirm everything is clear, and only then cook.
6. Instrument separation.
Never activate near other instruments. That eliminates the risk of direct coupling.
And finally, number 7.
Bipolar priority. Use bipolar whenever it's appropriate for sealing and coagulation. It just eliminates the risk of remote injury that comes with monopolar systems.
And crucially, we have to choose our access ports wisely to avoid that physics trap.
Absolutely. Avoid the hybrid cannula systems because of that capacitative coupling risk. Always choose an all-metal port system when you're using monopolar instruments.
Finally, let's touch on risks that extend beyond immediate tissue damage.
Sure.
The safety of both a patient with specific medical conditions and the surgical team itself.
Right. For the patient, especially those with implanted devices like pacemakers, electrical current is a major contraindication because of interference risk. In those cases, the harmonic scalpel is the preferred tool because it's friction-based, no current.
And what about the risk to the surgical team from the ESU plume, the smoking gas generated during energy use?
The ESU plume is a serious occupational hazard. When energy is applied, viral DNA, bacteria, carcinogens, and irritants are all vaporized and released into the abdomen. They stay compressed in there. At the end of the procedure, when the abdomen is deflated, that plume is released directly into the operating room air.
And the patient is only exposed once, but the surgical team is exposed to that every day.
Day in and day out. And studies have shown this material can be potentially carcinogenic. The safety protocol is clear. Strongly recommend active evacuation. The gas has to be actively sucked out of the abdomen at the end, not just allowed to diffuse out passively. It minimizes the team's exposure.
This has been an incredibly detailed and, frankly, high-stakes deep dive. We've covered centuries of progress, from the simple concept of therapeutic heat to complex automated impedance technology and purely mechanical ultrasonic energy.
And we've shown that safety and success in this kind of surgery depend not just on choosing the right $50,000 tool, but on mastering the granular variables of the foundational technology, the duration, the precise wattage, the tissue type, and knowing the fundamental limits that differentiate monopolar from bipolar. Safe surgery is absolutely precision physics.
The depth of this information, compiled by Dr. Senthil Kumaran K., Associate Professor of Surgery at AIIMS Nagpur, ensures that you now understand the crucial physics and protocols behind safe, cutting-edge, minimal-access surgery. This knowledge provides a whole new layer of appreciation for the incredible precision required in the modern operating room. Thank you for joining us for this deep dive.
Thank you.
And here is a final provocative thought for you to consider. We learned that the critical safety limit in electrosurgery is 100 degrees C, the point at which water boils and tissue chars, leading to a failed seal. If the human body is primarily water, and given the speed at which current operates, what are the fundamental technical challenges standing in the way of developing a sensing technology that can reliably measure and communicate tissue temperature in real time across a distance, informing the generator before that 100 degrees C threshold is ever breached? Think about the implications of preventing charring entirely in the most challenging procedures. Until next time.